Welcome back, everyone. Hopefully you enjoyed the keynote this morning. We had a great federal and state EJ legislation discussion. Also, well, not EJ legislation, a great report back state and county report back session. And now what we have is Dr. Cliff Mitchell going to talk about the Department of Health's Environmental Public Health Tracking Program. So I'm going to give a little bit of background on Dr. Mitchell, but we'll get started. So Dr. Cliff Mitchell is Director of the Environmental Health Bureau in the Department of Health and Mental Hygiene for the Department of Health and Mental Hygiene, Department of Health. His office was organized in 2009 and oversees the Center for Environmental Health Coordination, the Office of Food Protection and Consumer Health Services. Cliff has done a lot of work on issues around environmental and occupational epidemiology, healthy homes and community services. Also has been helping with the state's efforts around COVID-19 tracking. And as I said, Cliff coordinates the environmental health activities of the Department of Health. And in this session, Dr. Mitchell is going to talk about the state's environmental health tracking program. And what we're looking for in this session is a lot of feedback from attendees about what should his program be doing as it relates to environmental health tracking. Are there chemicals of importance that you would like to see tracked? Are there, right now the program, Cliff is gonna talk about this, focuses on, asthma, air pollution, some climate, radon and lead. Are there other things that they should be focused on? The areas of their priorities right now, are they getting to your community? Is the outreach material you need? Are the things they're missing? Or is there clarity in information? What do you need from this program to help educate yourself, educate your community, and to help improve environmental health? So please, be prepared, provide feedback. As Cliff said earlier on, he'll say this again, he really wants to improve this program. And so this discussion, we one of many discussions to help make the program more responsive to the needs of Marylanders, particularly those who are frontline and fence line, who have EJ issues, or who may be impacted by health disparities, including environmental health disparities. So I'm passing the mic to you, Cliff.
Thank you so much, Jacoby. I just want to make sure everybody can see the slides. So just thumbs up or something else. I'm assuming that people can see the slides. Excellent. Thanks, Jacoby. And first of all, I really want to thank Jacoby and his team at the University of Maryland for putting on this entire symposium. I've attended the symposium since it started 6 years ago, either as a participant or as a lecturer or both. It is, and Jacoby and I were talking about this earlier, it's one of the few places where you can really get a group of people together to engage in real conversation around issues of environmental justice in a way that is productive and probably in some ways more productive for me as an agency person because it is, I think, the participants are not bashful about criticizing and providing suggestions and feedback to the work that we are doing at the agency level. And my purpose in coming here today, as Jacoby said, we happen to be in the midst of a redesign of our program. So this is really an opportune moment for us to get feedback from all of you about the things that we can do better. So I want to start with a little bit of introduction. Many of you, I think, in this audience are familiar with environmental public health tracking, but for those of you who are not, the question really is, how do communities access and use data to address local concerns? This is really at the heart of, as you'll see in the next slide, what tracking was originally meant to be. Historically, health and environmental data have been collected, analyzed, and disseminated mainly through the state, through large centralized mechanisms. So for example, you go right back to the origins of public health data with the Dome book, with John Snow and the cholera pump. It was health professionals, statisticians, clinicians, public health people, even before there was public health as a discipline, there were, first of all, individuals who asked questions locally. But shortly thereafter, as people began to frame those questions as let's do this systematically, they built up large mechanisms to do this across the state in a standardized way. That provides a strength and a weakness. The strength is that it's a similar collection of data so that you can compare and contrast and understand what's happening across an entire state and across an entire nation. The weakness of that mechanism is that local questions and concerns are often subsumed into or totally ignored by the collection mechanisms that exist at the state. So we're really good at collecting things like births, deaths, statistics on illnesses. But several things make it really, really difficult to go down to the level where people at the community and the individual level can ask questions either of those data or locally to try to answer questions that are locally relevant. And if you're talking about access to the question and the question framing, you're talking about really, in some ways, access to power, because who frames the question oftentimes sets the tone and shape of the debate. And in many cases, if we're talking about what kinds of data we collect and what kinds of data we don't collect, and what are the rules for disseminating those data, those become centrally important to local communities in understanding and being able to answer questions at the local level. So I have a little graphic in here from the CDC about the National Public Health Tracking Network, which is a lovely, I wish I had the money the CDC had for graphics, because they do great graphics. And so we've got environmental data over here. I think I have a little pointer if I can do this. Yeah. So they've got a little environmental data over here. They've got exposure data over here. Then for some reason they have a body of water. I'm not sure why. Then they've got health effects here, and there's a body of water somehow that you got to swim across to get to health effects. And then you've got the population and its characteristics. This is a great graphic for a national program, but oftentimes it's really difficult to figure out how to apply this locally, because there are challenges with each one of these that I want to talk about in the context of what we do as a state. So a little bit of history, because I'm now old enough to remember this. Tom Burke, who chaired the Pew Environmental Health Commission report in 2000, and Lowell Weicker, Senator Lowell Weicker from Connecticut, was the commission chair. Lowell Weicker said in his foreword to the report, "We must have the basic information about the health of Americans and our environment before we can make the fullest use of this exciting genetic knowledge." He was using genetic in a broad sense. The way to get this basic data is to track it systematically, comprehensively, on a coordinated basis at all levels, from the local community to the nation as a whole. We have to track what and where the hazards are in the environment, whether people are at risk from exposures to these hazards, and the health of our communities. The focus of the Pew report, the focus of the early efforts of the tracking network, were supposed to be, and in our mind, many of us in tracking have always been focused on providing tools for local communities to understand their environment. Environment in the broadest possible sense of the word. Environment meaning the physical environment, environmental hazards, meaning the health environment, what is the health status of the community, and it's not necessarily, and this is really, really important to understand, it's not necessary to equate the hazards, and we'll talk about this in a minute. You have to draw, sometimes it's really difficult to draw a line between the hazards and the outcomes, but even if you can't do that directly, knowing that a community has high exposures and high health outcomes allows you as a community, and we'll talk about this, and because this is really one of the questions I really want to get to, is how does this kind of information help a local community in addressing both health disparities and health outcomes, environmental hazards and environmental outcomes, and what do we as a state do to help that process? And what do we do that gets in the way? Because we do a lot that gets in the way sometimes. So let me just talk, Jacoby talked a little bit about the epidemiology that we do. So this is basically an epidemiology program. We have a number of different things that we have with environmental public health tracking. We also have our climate adaptation tracker. And then we do a lot of cancer cluster investigations, and I'm going to talk about those. We have occupational health indicators, and we do injury prevention. We have the violent death reporting system and the state unintentional drug overdose reporting system. It's important to understand that while we're talking about environmental hazards here in terms of environmental public health tracking, you can't ignore many of these other exposures and factors when you're talking about the health of a community. So I want you to keep this in mind, because there are data that are potentially available to put on the tracking portal from all of these programs and others within the health data of the department. So this is a picture of our current tracking portal. This was designed, and I want to give a lot of credit to Min-Shi Wong and his team at the University of Maryland, who designed this portal. It's what you can access now currently as we start our redesign. And it has a couple of elements that I just want to talk about, because I want you to focus on these as we think about where we're going next. The first is, you'll notice in the portal, there's not a lot of text about the data. When you come here, we're not providing you with a lot of information about the data. It's really to try to get you to the data as much as possible. So over here, we have controls on how to map the data. We have similar kinds of controls if you want to make a table of the data, as is shown here in this little pop-up. And we do show you trends. But the goal of this original design was to provide you with an opportunity to get to the data as quickly as possible, and for people to explore the data without a lot of words or explanations getting in the way or us interpreting the data. Now, a couple of things about that. This portal was designed back in the mid-2000s, so it's more than 10 years old now. We launched it in 2008, and it's been constantly refined and improved since that time. But a couple of things have become clear as we move into the redesign. And as I show you the next couple of slides, I'm going to be asking you for your feedback on this, because I think that these are some of the things that we've learned. So as we revise the portal, we're thinking about a couple of different design elements that are not in the current design. The first is, and I'll show you a picture of this in real life so it's less conceptual. The first is, we want to not just have a map here, but very importantly, we want to actually have more text about what this is. An overview of the data, where the data came from, and then very importantly, we want to put links and resources and what you do about it as you look at the data itself. And then the other thing that's really important is to understand that we have some overarching themes that are going to be very much part of all of the data that we show, whether it's health data or environmental data. So those themes that are overarching will be, what is the status of the problem now? That is to say, right now, what does our surveillance data show us about this problem right now across the state and in various local jurisdictions? The second is, what's the source of the problem? As much as we can, we want to show you and have you and people who come to this understand how this problem got this way. For example, if we're talking about lead or asthma or other problems that are related to homes and housing, show you both in terms of maps and in terms of tables and in text, why those linkages are important, what we understand about them. And then the third sort of big overarching theme is, what are we doing about this? Because at the end of the day, just showing you data is not enough. It's also important for you to understand what can be done, what is the state and what are local communities doing to fix the problem and address this issue. That's really the sort of overarching theme that we're going to try to build into this new portal to better help explain what it is, as we understand it, is the problem, the source of the problem, and what is going on to fix the problem. The other thing I want to say is that as we show surveillance data here in this main map, one of the things that we will also do, we will always have information about disparities as part of our data display. So we will, as much as the data permit, try to have in every theme, whether it's lead, asthma, radon, air quality, water quality, whatever it is that we have, we will say something about and have some data on, to the extent that we can, about racial and ethnic disparities and other disparities that we understand about exposure or health outcomes. The other thing that we'll have maybe over here, it sort of depends, is we'll always talk about trends so that you can see not just where we are right now, but whether we're getting better or worse. So if I can show you just an example of this, this is what a mock-up of the lead page might look like, where we show you blood lead levels, we show you where the problem came from in terms of housing and lead paint, which is one of the big causes of lead poisoning here, and then what you can do about it or what is being done about it, testing and services. And as I said, these overarching themes of equity and disparity, and then what the state is doing, will be echoed and continued through all parts of the portal. And then over here, we'll have, depending upon whether people like this or not, we'll have information about the problem, and then resources that are available and services that are available. So that's a kind of that's what we're thinking at the moment, and I'm going to come back to all of you for feedback on this shortly. So if you think about what another example of this might be, this is our current climate change project, and this is called the Environmental Public Health Climate Adaptation Tracker, or EPHT for short, because no program is allowed to exist without a catchy acronym. So as in the same way that I said that the issue of resources and services are going to be echoed throughout, as I said, we'd have the main map up here, description about local efforts. And so if you click on one of these little blue buttons, each of these is an adaptation effort that is going on currently somewhere in the state. These are local adaptation projects. These are not state initiated, these are locally initiated. And down here, we've got an inventory of these, which we've just completed our most recent update on, a way to access them, who's involved, what the climate stressor or issue is that's being addressed, what the purpose of whether it's supposed to be a project that focuses on the state level or a local level, and our goal is, and one of the things we really want to do is engage with local adaptation efforts to try to track more of these, to provide local communities the opportunity to see A, that they're not alone, but B, to share resources with each other. So that's part of the goal of this project, both with Environmental Public Health Tracking, with the Adaptation Tracker for climate change, and with the project as a whole, to be able to share more resources amongst people at local communities so that they don't have to reinvent the same wheel on an ongoing basis. I mentioned also that we have a program in occupational health. So here we have rates of work-related hospitalizations by county per 100,000 Black employed persons and by 100,000 white employed persons. And this is, again, one of those themes that I said we would carry through the entire project, which is wherever we have data on disparities, we want to present those data. Now, we won't necessarily have answers to all of these questions, but part of the goal here is to provide the kind of information that people can use to understand what's happening in their local community, and, for example, how to understand the distribution of racial and ethnic exposure and outcomes that are distributed across the entire state with respect to these environmental and occupational hazards. So this is yet another example of where we'll try to use these kinds of graphs and tables to share with you and with local communities and everybody, including policymakers, what we understand about disparities across the state with respect to environmental hazards. Now, Jacoby mentioned the fact that you won't know whether or not something is working unless you evaluate it. So if you look at, for example, our 2016 initiative, which changed the lead testing requirements for healthcare providers so that now, rather than testing children who come only from urban centers, we are now testing every child or healthcare providers are required to test every child at age 12 and 24 months for lead poisoning, whether they live in Cumberland, Baltimore, Bowie, Green Spring Valley, Montgomery County. All those children are supposed to be tested. And an important part of what the state does, or should be doing, is evaluating its own interventions to see whether they're working or not. This is the use of the data that we have to look at different models in order to select the most appropriate lead testing strategy, and then look at whether or not, as we move into implementing that strategy, whether or not we're doing a good job and whether the strategy is working. So one of the other things that environmental public health tracking is going to be doing is to be presenting this kind of information along with the interventions itself. So on our lead page, we'll talk about the things that work well and the things that do not work so well in terms of implementing the interventions and what we're trying to do to improve it. Another example of this is radon. So this is our state interactive radon map. This map allows you to click on any point here and see the number of tests of homes that have been tested for radon and what those radon levels are. And the colors here indicate whether or not this is a high radon geology or a medium or a low radon geology. So our goal is to encourage testing across the state, but especially in areas where the geology in the Appalachian and the Piedmont region, moving into this sort of central region of Maryland. Our goal is to have people test their homes because radon is the second most preventable cause of lung cancer in the state and in the country and the nation and the country as a whole. The first being smoking, but if you take away tobacco, radon in the home is the most preventable, and it's easily prevented risk for lung cancer. And it's easily correctable, but you'll never be able to correct it if you don't first identify it's a problem. So we really want to encourage people to test. So that's about a half hour or so of me talking at you. And what I want to do now is invite you to engage in a discussion about what we can do better here. So I really am interested, and Jacoby and Yasmin, I'm going to I'm going to take notes here as we do this. I've got some other folks who are taking notes in the audience as well, but I'm really interested in what you all think are things that, as you look at this, are problems, are things that you think work well, whether you've ever used our site before. I know many of you know about the University of Maryland Environmental Justice EJ Screen tool. It's important, and we can talk about that because that tool is very valuable. It has a different emphasis than our tool, but we want to work in synergy with other tools as well to try to help people understand the context of their neighborhoods, their communities, and to be able to address important environmental justice problems. So Jacoby and Yasmin and Joe, I'm happy to let you, because I guess I can, if
yeah, go ahead, Cliff, go ahead.
What I was going to say is I can't see the chat because I'm sharing my screen. So I can either get out of this and then we'll go back to the green screen and I'll take notes myself, or if you want to moderate and pose questions with me and control the flow, I'm okay with that as well.
Yeah, what I want to do, Cliff, it'd be good if we can access the chat, but I think for the audience, maybe going back to some of the slides will be helpful too.
Yeah, so that's fine.
Yeah, if we can go, let's go back to that first one. We had I think you had maybe the asthma was, which one was that?
Yeah.
I'm not sure if it's that one, but let's go to the lead example. Let's go to the lead example. I'm sorry, Cliff.
Okay, that's fine.
Yeah.
Yep.
So what I want to do is Cliff said, is open this up for a discussion. He really wants to get feedback on content. You know, what should we be including in EPHT? How it's presented. So the presentation, the information, right, and the usability of the information are things that are important. And then and as Cliff mentioned, some of you may not know. This may be your first time hearing about the EPHT program. You know, what does that mean to you? I mean, it's your first time hearing it. How would you like to use it? So let's get started. I'm not sure who wants to get started in the chat. And then also for Joe, Yasmin, we're also are we using the question function too?
Unfortunately, the question function is only in that bigger main room. There's no.
Okay. Let's just use the chat. Let's just use the chat then.
Yeah, and alternatively, I'm perfectly okay if I don't know if you can unmute people, but I'm perfectly okay to engage in a conversation. And sometimes people would prefer to speak. I'm okay with that.
Yeah, so we can do that as well. The only issue is, you know how that bandwidth, we start to lose a little bit of bandwidth. We have too many. So do you want to do how we can do it? Maybe no faces, but you can just unmute yourself so we can keep the bandwidth. I'll turn my face off too.
I'm happy to turn my face off, but
okay.
But at least somebody will be there to be the poster child, as it were, for the program.
Okay, well, Cliff, if you want to go off air, I'll stay on air then. And then Selena, can you go ahead and turn yourself on, or Yasmin, give her access so she can ask her question? Go ahead, Selena. You can go ahead and you can verbally ask Selena. Go ahead. Oh, you don't have a speaker. Okay, I'll take care of it. So Selena asks, how do we identify specific EJ problems communities in Montgomery County? Can they be identified by zip code?
Yeah.
Can you ID COVID-19 related illnesses? So that's Selena's question. Thank you, Selena.
Thanks, Selena. So it turns out I do a lot of work like everybody else with COVID-19 these days. And so, yeah, I can answer that question. So two things. So, part of the challenge that we have is when the data are collected, they are collected by geography. So there are different kinds of data. For example, lead data, we actually know the address of the individual, of the child that's tested. And so we can show that kind of, and same thing with COVID-19, since we know the address of the person, we can show that data at any geographic level, whether it's census tract or zip code or county, any of that is possible. The only limitation is that, and this is one that frustrates, I know, everybody, there are laws and policies that protect privacy, that prevent sometimes the display of data at the very, very small level. So for example, at the zip code level or at the census tract level, we can currently display cancer data. But if you have a cancer that is relatively unusual, like an osteosarcoma or something like that, there may be only one cancer in your zip code every 5 or 6 years. And in that case, our policies require that we not show that zip code with only one cancer, because it is potentially possible to identify that individual. So as long as we can meet those geographic cell suppression rules that preserve confidentiality, with some data that is address level, like COVID data, we could potentially show that at any level. With other data, for example, hospitalization data. So if you're hospitalized or you go to the emergency department, when those data are collected by the state agency that collects them, the Health Services Cost Review Commission, they don't collect or release individual address level data. They only collect zip code and county level data. So you can't do anything more fine-grained than zip code in terms of the display. And I don't know if you've looked at a lot of zip codes, but it turns out zip codes are a lot bigger than neighborhoods. In most cases, zip codes involve an entire community or many communities. And so one of the frustrations is there are limitations in the data that don't allow us to show some kinds of data at a level that is the same thing as the community level. Yeah. So Selena, I don't know if that answers your question or not, but we try to show the data at the lowest possible level that we can given the data.
And just to, before we move to the next question from Janet, just to follow up on that, Cliff. So what's happening in Baltimore City with their health tracking project, their health indicators project, and how are they doing that?
BNIA, the Baltimore Neighborhood Indicators Alliance. The thing that Baltimore did years ago, which is really terrific, is they identified actual neighborhoods. Now, those neighborhoods are what the people themselves identified as the neighborhoods, so Stoneleigh or Curtis Bay, South Baltimore, Pigtown, the other neighbors, Sandtown. Those neighborhoods were all identified by the people living there. And the thing that Baltimore did, which most other communities can't do, is there are enough people in Baltimore and the neighborhoods are clearly enough defined that they were able to actually show data by the neighborhood regions that are familiar to people. In most cases, throughout the rest of the state, that's not possible to do for two reasons. The first is most neighborhoods aren't that well defined historically. And then the second is that in most parts of the state, there aren't enough people living in any one given area to have a neighborhood that's really smaller than the county level. So that's part of the challenge of, or the community level. So obviously Bowie and other places are defined, but those geographies are not standardized geographies by the state or any other political boundary. They have to be self-defined.
Okay, thank you for that, Cliff. And then she had another question you didn't get to yet, Cliff. You want to talk the EJ specific problems? How do we identify specific EJ problems in communities in Montgomery County?
Yeah, so that's a really, really good question. And I think that goes to the heart of what we would like to be able to do, which is to say, the goal here is not simply to provide data, it's to provide meaningful data. So the best thing that we could do, I think, from a state point of view, is to work with local communities and county health departments to address those questions that the communities themselves identify as important questions. We may or may not have the data for them. It doesn't mean that we can't still address the problem. But if we hear from people that this is a really important problem, that's really the way we can start to incorporate those issues into the Environmental Public Health Tracking Network on a statewide level. a lot of problems we're going to face are, do we collect the data or not? And we collect a lot of health outcomes data, and it's possible to put a lot of it in there. We want to hear from you all about what are the most important problems that you feel you need answers to, and we can work with you to try to either provide those data to you on an individual basis or actually put it into the program so that it's there for all communities to see.
Thank you. So Joe, can you put in the chat the link to the EJ screen tool? So Cliff mentioned it briefly.
Yep.
Early on in the comments.
Yep, I'll grab it.
So we have developed a, just real quickly, US EPA has their environmental justice screen tool that allows you to look at environmental justice issues at the census block group level. We've advocated, many EJ advocates advocated for states having their own tools. So right now there's 4 or 5 states that have their own tools. The one that's really highly active is Cal Environmental Screen, which is a California EJ screen tool. Washington State has a tool. Michigan's developing a tool. North Carolina's developing a tool. New Jersey has a tool. But we, Maryland, also have an active tool. Not the same level as California, Cal Environmental Screen, but we have Maryland EJ Screen. So that tool allows you to look at environmental justice concerns at the census tract level. And so that may be a tool that'll be helpful for you to use in Montgomery County. And Joe has put it in a link to the tool in the chat. Okay, Selena. Okay, so let me move to the next question. Janet has a question, Dr. Mitchell. Is there a tool that enables comparison of 2 maps, such as comparing the map of COVID cases with the map of PM 2.5, or COVID in a map of equity enhancement areas, or PM 2.5 in a map of equity enhancement areas?
Yeah, that's a really, really good question and a really good suggestion. As I said, since this is under design, those are exactly the kinds of ideas that we'd like to hear. We actually do have we certainly have the capacity to show that kind of comparison. Part of the challenge is figuring out, and this is a challenge that Jacoby I'm sure can talk to, is defining an EJ area is not a standardized definition at this point that is, from a demographic point of view, necessarily easy to do. And so I think part of the challenge for us is thinking about how we create, and we have talked about this a lot, created either indexes or other kinds of indicators that can be used to define EJ areas in a way that you can then overlay those maps. So the EJ screen tool and other tools do allow you to sort of understand what the hazards are and what the risk scores might be. And so that is one of the things we're actively talking about, is how do we address this issue of showing equity and disparity in environmental justice areas and concerns in a way that allows you to do exactly that kind of comparison. So thanks for that question. It's a really, really terrific question.
Well, thank you for that. So Joe, that's not the right link. Remember, there's one link that's not working, and that's the other EJ screened. It should have the D at the end.
I checked with Yan, and I believe that this is the most up-to-date link now. Okay,
so sorry for Maria. I'm not sure why it's not working, but can you check in with Yan to let them know that the link is not working? Kate said we got a tool and send people the link, and the tool's not working, y'all. That's just not a good look.
Great.
I just clicked on the link and it works.
Yes, and I can say, so let me just say this about anybody who's ever done any work on a website. I feel the pain of anybody who has ever tried to keep a website up to date, working and functioning. And I never laugh about the travails of somebody whose website is not working, because I know from personal experience just how frustrating it is to keep that thing up to date and working all the time.
Oh, thanks for that, Cliff. But we think it can be used as a resource to answer some of these EJ questions.
Yep.
So yeah, so Maria, it should be the same Yeah, it's the same link. So if you go on the resources at the siegelab.org site, it's the same link that Joe put into the chat.
And for Selena's comment about the zip codes for the county council, that's really very helpful information. So thank you, Selena, for that, Ms. Singleton, for that information. That's really helpful. For Bonetta Adib, the census tract level, we do, so, and that's a really good question. Those of us who are epidemiologists by either profession or because we've fallen into it, have come to have a love-hate relationship with zip codes. Mainly because zip codes are not static. They tend to move around. They change when the Postal Service decides that it's time to either take them away or reshape them. They're not standardized in any way. So they're useful for the delivery of mail, but they're not very useful from the point of view of showing about people's lives. But the problem is that census tracts, no one happens to know their census tract level off the top of their head. I do,
but Cliff, we need to actually transition away from zip codes. Like, you should know your zip code, but you should also know your census tract.
So that's, I think, I think there are two important lessons there. One is that we are trying to push our data systems to collect more information at the individual address level and at the census tract level. Because I think I agree with Jacoby about this. It is absolutely important to move away from zip codes because they don't allow you to do comparisons. They're terrible for historic comparisons purposes, and they make life more complicated. That being said, right now everybody knows their zip code, and very, very few people know their census tract. So my advice to you is, A, know your census tract, but even more important, if you know your address, you know your census tract.
Exactly.
So we are very much trying to move more of our data to census tract level data. Our cancer data is there, our lead level data, lead test data is there, but the hospitalization data, which is the most important data to understand people's illnesses, is unfortunately only available right now at the zip code level until we start collecting it at the individual address level.
Oh, thank you for that, Cliff. I think those are really important points about when you're doing surveillance, your unit of analysis, it may not be a useful unit of analysis. It may be useful politically, right? Because we know, like you said, with mail, zip codes, but when it comes to surveillance and tracking impacts of policies and looking at neighborhood level impacts and changes in health outcomes based on those policies, they're not useful. So I think for those of you out there who are using these tools, you have to have those caveats in mind. And those of you out there who work for county council, work for delegates, who work in state agencies, like Cliff's agency, how can you, improve the tools so they can be more useful for the people? That's the point of these tools, right? That's what Cliff opened up with. We wanted to make sure this information for EPHT is actually useful for local folks. So
there's another comment, Jacoby, from Tony Garcia.
Yeah, I was gonna get to it. So
yeah.
So Tony's comment. So what would you be able to talk more? Can you talk more about how the lack of data is addressing these tools and why it's important for more community-based science in helping to provide data for these mapping platforms?
Right. So I'd like to take a little bit of time to talk about this because I think it shows both the power and the limitations of state systems. And I'm a big believer in self-criticism. My staff probably thinks not quite enough of a believer, but that's a different issue. But let me give you a couple of examples of how and why it's really difficult as a state agency to do that kind of sort of individual community level data. We've had a lot of discussion about whether or not, for example, we would and could allow people to put their own data up on our map and to do essentially that community-based science. And I love the idea of community-based science. It is really, really strong, powerful, and for those of you who are in the environmental justice community, you know full well, and I will be the first to admit this, there's a natural inclination on the part of many state health authorities that if they haven't seen a problem often, that problem is not very likely to occur. This is a problem which is the bias of all scientists, which is that they're informed by their history, and in many cases, people who first started talking about environmental illnesses caused by local pollution were said, oh no, we've never seen that. That probably isn't a thing. And it was local scientists like Beverly Pagan and people who worked in Woburn and people who worked in Libby, Montana, who said first, before any of the health professionals, you know what, there's really something that's really wrong here. And they oftentimes did the original work. It wasn't elegant all the time. It didn't have the right controls. It wasn't rigorous. But at the end of the day, it was often the data and the science that moved policy. So I'd like to sort of talk to you about cancer cluster investigations as an example of both the strength and the limitation of local data. So several years ago, the people in Frederick, Maryland were concerned because of the presence of what they thought were excess cancers occurring in the area of Fort Detrick, which, as you know, is the home of the United States Army Research Institute of Infectious Disease. It's the place where Agent Orange was developed. It's got a long history of working on both chemical and biological agents, and the people who live around Fort Detrick were concerned that there was more cancer there than there ought to be. We at the State Health Department started a project which ultimately involved about 4 years worth of work to try to answer that question. And along the way, one of the things that happened was that a local community group actually decided they would like to map the cancer in that area. Now, we had developed, using the Maryland Cancer Registry, a very, very thorough map of the cancer that we understood to be in that area from the Maryland Cancer Registry, which is the official registry of all the cancers that occur in the state. We had shown that map so that people understood where the cancer was across Frederick. The people in the community said, we would like to we'd like to do our own cancer map because frankly, we don't think that you've identified all the cancer that's there. So they created a map and they basically allowed people to report in a kind of a survey monkey fashion to a big map which went online, which showed much more cancer than we had identified. And so we engaged in a series of conversations with the community basically about what that meant. And it turns out when you're talking about what is cancer, if people are identifying their own cancers, they may identify everything from brain cancer to metastatic colon cancer to skin cancer to all these other cancers, and they don't always report it in a standardized fashion. They might identify several cancers as being all different cancers when they're actually biologically the same. They might identify the cancer because a metastasis to the brain might be called brain cancer, but it actually might be metastatic from, for example, the lung. And so it's actually a different cancer type. And this is not a criticism. It's simply an acknowledgement that plotting that kind of data and recording it requires a huge amount of curating and looking at and examining and understanding and refining and quality control and various other things. And it's not to say that they were wrong. They were identifying the cancer that they understood, but they were doing so really in a way that made it very difficult to make comparisons with any other cancer anywhere else. And it was really difficult to use it for policy purposes. That same kind of challenge exists if you're a state agency and you're thinking about allowing the public to essentially map their own either health outcomes or environmental exposures. It's most useful from our point of view if we understand where the data come from, how they're collected, how they're analyzed, how they're reported, and all those other things. And it takes a lot of infrastructure. And so the challenge of community-based science in this kind of mapping is how to do it given the very limited state resources that exist in a way that is most useful to the community and most useful to the state. And so Tony, I don't know if that answers your question, but I love the idea of actually doing it. I will say that the state, given the number of epidemiologists we have, all the work that it takes to do it, it's not an easy thing to do. And if you're going to do it, you should try to do it well, because if you don't do it well, it can lead to some unhappy consequences in terms of, in some cases, moving policy in a direction you don't necessarily expect. Or, I mean, it may work very well, but if you're going to talk about it as a state agency, it's a really complicated issue to do. And I have to admit, that answer doesn't always make everybody happy. And I find myself balancing my desire to do it as much as possible with the realization that given all the things there are to do and how complicated it is, it's not an easy chore. So that's a really long answer to your question, but it's a really, really important question. And I welcome discussion on it.
Go ahead, Tony, you want to chime in real quick?
Thanks. Yeah, this is Tony here. And thanks for the discussion on community science. I think it's an important discussion to have. And just a quick follow-up, just for some of these maps, does it show or identify areas where more data is needed then, whether it be community science or data from, wherever it took place the first time? Does it identify those holes? So besides the question of community science, how does it show where there are holes in the map, holes in the data?
Yeah, no, that's a really, really great question. And the way we do that is there are great big holes in the map, white spaces. And the white spaces are where we either have to suppress the information because there's too few data, or where we don't actually have the data. It's a really great question, and our map people hate white holes. They really do. They don't like white space. They'd rather fill it in with actual data. So, but it does very much. We do our best to show not only what the data show, but also where there are no data or insufficient data. So it's a great question. Thanks. So go ahead, Jacoby. Where are you now?
Okay, yeah, sorry, I was muted. So just to follow up on that, yeah, I think it's important. I mean, Tony and I are engaged with the Citizen Science Association. Many of you may not know what the Citizen Science Association is, but it's an association where we uplift and support the use of citizen science, just in general, getting people more engaged in science. It's a democratization of science. So talk about data transparency, data interoperability, data reliability, data quality. We have environmental justice practitioners work group, which Tony is a co-chair of. I'm on the board of the organization. I'm there to talk about JEDI issues, justice, equity, diversity, inclusion issues, bringing in environmental justice focus. We have an ethics working group. We have sort of a diversity, equity, inclusion working group. We have all these different working groups, right? But one of the things that entity and other entities out there, like APHA's Environmental Justice Committee, Community Campus Partnerships for Health, also the Partnerships Environmental Public Health Program. There's a lot of folks advocating for more citizen science collected data. And when we think about mapping, there's a term called story mapping. There's also another term called GIS, public participatory GIS. And GIS is Geographic Information Systems. So you build your own map. So there's power in mapping, as Cliff is saying, and what Tony's saying. also, as Cliff is saying, we have to make sure it's rigorous. So I think, Cliff, what we have to do, and I think EPA is doing this its own with Citizen Science Toolkit. There's academic institutions that are doing this. There's nonprofits like this is nonprofit. Those of y'all may want to check it out, called Public Lab. Public Science, is it Public Science or Public Lab? I think it's Public Lab. They do a lot of great work engaging communities around community science, citizen science, creating maps. It's a great organization. It's the quality assurance plans, making sure that we have protocols where we know how we're collecting data, that we're doing a duplicate and triplicate, that we're bringing in rigor and reliability. And I think that in itself will help improve the quality of data and increase the confidence of community collected data, that then it can be mapped. And what we talked about doing with EJ Screen is actually, hopefully having a tool which allows folks to upload their own data. That's part of the future of that tool. But as you said, Cliff, it depends on the data quality. We have to have some caveats about the data. And when we integrate this, and I think that's something we could do with the Maryland Environmental Public Health Tracking Tool too, is have caveats, like your quality assurance plan, based on what you did and what you didn't do. This data is high quality, medium quality, low quality, and this is what we can do with. Go ahead, Cliff.
Yeah, no, I couldn't agree with you more, Jacoby. I mean, ultimately, at the end of the day, there are two, and we know this from practically every aspect of what we do. There are too few people who are professionally doing public health to do and all the monitoring that needs to be done in the local level. So in some ways, the ideal is that we turn loose the power of local communities to do their own monitoring. I completely agree with you about that. And I also agree with you that at the end of the day, the best thing that we can do in some ways is to provide technical assistance and resources to people who want to do that themselves so that they are able to do that themselves. And ultimately, if that happens, we will get to the point where those data become as useful and valuable and standardized and comparable as the data that are collected by EPA, the Maryland Department of the Environment, and the Maryland Department of Health.
Very important. Thank you for that, Cliff. And just to chime in and maybe kind of get us linking back to some of the questions that Cliff had for us, speaking about that issue, Cliff, and air quality, right? We know that, we don't have a lot of regulatory grade sensors out there to measure criteria air pollutants. So you may see a map that shows a spatial gradient of particulate matter, but that map is based on very few data points, right? So getting back to Tony's point, Tony's from Milwaukee. We got folks online from different parts of this state, right?
Yep.
If you have multiple hazards, speaking to our other conversation, are you really getting, as Tony said, the right data? It's not a gap, it's limited data, right? And that's the power of what we're talking about, of communities collecting their own data to improve those estimates and improve those interpolations, improve those maps. Go ahead, Cliff.
Yeah, and I couldn't agree with you and Tony more about that. So if you take the example of particulate matter, PM 2.5, PM 1.0, the one thing that we know about that is that that's very localized data. It can change over the matter of 500 feet. And at the same time, we've got one air monitor for PM 2.5 that covers all of central Baltimore. In fact, practically all of central Maryland. And it doesn't tell you anything at all about the PM 2.5 that people who are living in Bowie, who are living on Sheriff Road in Prince George's County, who are living in Green Spring Valley. It calls them all the same. And we know that that is not the case. It would make me incredibly happy to have people walking around with reliable PM 2.5 calibrated sensors that they could record locally and on an ongoing basis feed into a map that would show where PM 2.5 really is across the entire state. Now that's the Maryland Department of the Environment that regulates that. But in terms of thinking about what local exposures are, there's no way to understand local exposures because they vary so much in terms of geography by the stationary air sensor that's located in Clifton Park or somewhere else.
Yeah, no, exactly. So just as I mean, so for example, the follow up what Cliff just mentioned, we're working with St. Mary's County. We just had a meeting this past week, and it's related to environmental public health tracking. They have a lot of kids with asthma. They have asthma hotspots. Kids are inside more due to COVID, right? And so our kids experiencing more asthma symptoms, asthma attacks, hospitalizations, but also there's no real monitoring in St. Mary's County. So we're talking building a county-wide air quality monitoring network using both low cost and federal equivalency grade sensors, which y'all need to worry about what that is.
Yeah.
But the point is, there's not enough monitoring. This county health department wants to do more monitoring. We're also working in Cheverly to build out a monitoring network because you heard Delegate Ivy, for those of you who were earlier on about Cheverly, there's concrete batching plants. There's a metal recycling facility, a junkyard basically. And then there's also highway pollution that community is experiencing, right? So this is one of the ways that you have this. So EPHT provides background information around air quality and asthma. So information that can be used to educate for outreach, right? And you have these basic maps, as Cliff mentioned, but then to improve that, as Cliff is saying, will be good. And MDE, we had this conversation earlier, Cliff, with Secretary Grumbles about that's part of what we heard from the delegates, Delegate Charkoudian, Delegate Learman, Delegate I. We got to do more air quality monitoring. But we also heard from Kelly Crawford from DOEE that monitoring is great. We also have to have more mitigation. So getting back to your point about your climate adaptation projects, right? Where are the mitigation projects too? Been in the map. So I want to kind of connect the dots a little bit. And then I want to get back to what Cliff wants. Cliff also wants feedback, y'all. So now this is a good conversation. Let's kind of get back a little bit to the EPHT. So Cliff, if you can go to, so as Cliff is showing this lead example, and I see there's questions in the.
Oh yeah. So can I get to Janet Gingold's question?
Oh yeah, go ahead. So I just want to get you. I'm trying to help you out, Cliff, but go ahead.
No, I really appreciate that, Jacoby, and
go ahead.
And thank you, Janet, for that. So it turns out we are actually doing one of the things that we're doing through EPHT is a project with Garrett Knapp and the people at the National Center for Smart Growth down at the University of Maryland College Park, right across from where Jacoby's office might be someday, if he ever returns to the office.
Oh yeah. Not to the summer 2021, man. Go ahead.
Yeah, but that question that you are asking is a really huge question, which gets to the issue of health impact assessment, which is if you've got a transportation project, how do you think about the health impacts of that transportation project with respect to environmental justice? And one of the things that we're trying to do is create, and Garrett's been working on an integrated transportation and health impacts model, which looks not just at things like air pollution and the relationship to lung disease, but also things like injury. Because if you change vehicle mode or transportation mode, you also change the likely distribution of injuries. And we're trying to do this idea of an integrated transportation and health model because when you want to look at, you don't want to look just at air pollution because clearly if you put a highway someplace, you're going to change air pollution. But you're also going to change, importantly, noise. You're going to change injury patterns. You're going to change other things. And one of the things that we need to do, and where this becomes relevant, is this idea of, in the same way that we look at what's called the environmental impacts of a project, we ought to be looking at and providing tools for people to look at the health impacts and the environmental justice impacts of these projects. And so the first part of that is complicated enough, which is how do you figure out the health impacts of something that doesn't exist right now? But there are ways of doing that by framing the question, by figuring out what data you need, and then creating a way for doing this kind of health impact assessment. But one of the things that's absolutely critical about that, which Janet, I just want to get to first, is At the very beginning of this talk, I talked about the fact that who controls the question basically controls the outcome. And so a critically important part of health impact assessment is making sure that the community is part of framing the questions at the very, very outset. And one of the things that is most important, and the legislature has had a health impact assessment task force. There's been discussions about health impact assessment in years past. One of the most important parts of health impact assessment is engaging with the community right at the outset to make sure that there's a clear understanding of what the questions are. And to my mind, that's important to do whether it's an environmental justice community, whether it's a Green Spring Valley community, whether it's a Tony neighborhood in Montgomery County. The first and most important question of any sort of health impact assessment is, what are the questions that are important to the community? And oftentimes, it may not be the questions that are important to the transportation planners and the health folks. It may be other questions altogether. And part of health impact assessment is the idea of that you oftentimes may find that if a project is being proposed, there are trade-offs that should become part of the discussion or can be part of the discussion, but you won't know about that unless at the very outset people say, well, these things are important to us. So that's part of, I think, what that frames that discussion about environmental justice discussions of, for example, a proposed highway project.
Yeah, and just to chime in on that, and I think that's very important, relevant to Maryland and DC because of some of these expansion projects we're dealing with right now. Main cases when you do the environmental impact statement, which is part of the NEPA process, the National Environmental Policy Act process, they may do a transportation impact part, like how many more vehicle miles traveled will have, safety impacts. But Cliff, as you know, the air quality part of it may be weak because, again, as you said earlier, they may be using data from a monitor that's 20 miles away and not actually collecting baseline data. So it's part of the HIA process. And this is one, again, I'm gonna link this back to EPHT. How can we use environmental public health tracking in data as part of a health impact assessment process, right?
Yeah.
So you want to look at what are the baseline environmental hazards. So you see this program is focused on, you talked about radon. That's not as relevant for this discussion. But we're talking about, asthma. That's not environmental hazard. That's a health effect, right? But some of what are the air quality pollution sources that you may want to see EPHT focus on more, right? That's something that y'all want to maybe put into the chat. Like, so you're talking about highways. What are other pollution sources that, EPHT should track more, right? The hazard side of it, right? As you talked about that CDC slide, Cliff, I'm not sure you want to pop it up again, how the communities access and use data to address local concerns.
Yep.
Yeah, if you pop that one back up, Cliff. So go back to the environmental and exposure side, right?
Yeah, so if you're over here on the environmental and exposure side, that's a very critically important part.
Yeah, so what are those hazards that you want to see EPHT, focus on? See, Cliff talked about this partnership, highway expansion projects, current highways, current byways, other pollution, stationary pollution sources that should be highlighted more, should be included more in this tool. I mean, so in the HIA, that baseline hazards is going to be important. Baseline health outcomes. So again, getting back to EPHT, so we're talking about asthma and hospitalizations. You have lead poison, right? Also currently EPHT. But Cliff, beyond that, you have very little other health data.
So we actually have a ton of health data and more that's potentially available. So in our new tool, we will have,
okay, cool.
we have cancers of many different kinds. We have respiratory disease other than asthma. We also have cardiovascular disease, and cardiovascular disease is a huge topic. Diabetes is one that we struggle with because of the question of the definition of diabetes and the data sources, but that's one of the ones that we've talked about. And then birth defects. Birth defects are challenging because there are frankly rare events in many cases, comparatively speaking. So oftentimes, a lot of those data are suppressed at the neighborhood and local level because they are so rare, and we have to aggregate them over many years just to be able to have enough data to show at the local level.
No, thank you for that, Cliff. So I just want to chime in again. So getting back to this slide that Cliff has with health effects. So Cliff was able to say there's a lot more data. So they have asthma data, y'all. They have cancer data. They have heart disease data. You have the lead poison data, of course. You have I think you got you have the reproductive and birth outcomes data.
Yeah, we do actually. Very low birth weight, and then mortality data. Mortality data and life expectancy.
Okay, so these are all the kinds of data, y'all, that y'all can use. So the hazard, so if you're doing a health impact assessment, and we're going to talk more about this, I think, in a session on EPHT on the 10th. So how you can dig more into the applications of the data, okay? But these are the kinds of data you have access to that'll be really useful for health impact assessment. So I just want to make sure we're connecting those dots, Cliff, as we go through this discussion.
Yep.
Let me see. So you answered that question. Now, are there other questions, or you want to go back to your slides again, Cliff?
No, so I'm happy to provide the slides. I think I've already provided a copy of the slides. They're slightly out of order, but they are all there. Joe has a copy of them already, and Yasmin, and so yeah, I'm happy to make those available to everybody. Okay,
cool. Thank you. So let's go. You want to go back to your layout slide? Maybe not the lead one. What's the second one you had?
So the one question for everybody, and this is a question that we wrestle with, is how much to talk here. I mean, I think we have a sense of what things we want to say, but the question of how best to talk about environmental justice and disparities, not just from the data point of view, but also from the discussion point of view, in terms of what are the links and resources that are very important for people to have access to when we talk about EJ and disparities data. What are the links and services that people feel are important? And if you all think that there are certain, we tend to link to government sources because we're a government agency. But I welcome your thoughts about how to also provide access to reliable sources who can address EJ issues sort of from the point of view of being good resources for communities. So who are those people?
So for those of you we're thinking about what Cliff's question, we just don't want to problematize. The data can help us track the problems, but as Cliff said, who are those partners, resources that can help us with the solutions? So the folks before, Benita, I see your question, but do y'all have any ideas for what resources they should be linking to? Because in the end, we want to solve the problem. And we want to maximize the utility of EPHT. So EPHT cannot just be on the problems and visualizing the problems. EPHT should also be a resource for helping solve the problems. Okay, so who are those partners? Who are those players? Who are those nonprofits? Who are those entities that should be that you think may be helpful as it relates to making EPHT data useful on the solution side? You can either put it in chat. See you, Maria. Thanks for the questions.
Maria, thank you very much. I look forward to talking with you again soon.
Add to the chat, or you can just get on, you can just use your mic.
Right.
Resources.
Thanks, Cliff. Thanks, Jacoby. Sorry.
Take care, Maria.
Take care. Bye-bye.
Yeah, bye-bye.
So this is Selena. The Montgomery County Council will start putting together racial equity and social justice impact statements for certain bills. And the Office of Legislative Affairs, which is a separate agency, but also within the county, will be writing those within sort of a 3-week period of when a bill is introduced. So the bill is introduced, and then there's a public hearing, then it goes to a committee, and many of the health ones will go to HHS, to the Health and Human Services Committees. So there needs to be a really quick turnaround, and it would be easier for them if there is some information that they can find. The reason I was asking about zip codes is because typically a council member will rattle off, well, 20902, 20906, 20904 are where the COVID-related illnesses are going up. And so they know that off the top of their head.
Right.
Tax, I don't know, I'm not going to say they don't, but I'm just saying, the letters that come in from constituents are, 20906 or whatever. So, to the extent that there's some way to work with local legislators, Office of Legislative Affairs, county council offices, I think that would be helpful. There are also attorneys and analysts in Montgomery County anyway. So that would be helpful. That's where I was going with my initial question.
Yeah, Ms. Singleton, I think it's a terrific question. And the one thing I would ask is, I don't know if you've had a conversation with Dr. Gales.
Every day.
But it might be worth asking Travis that question. And he and I work together on a whole bunch of things. And, the extent to which he's very obviously closely linked to the state COVID, but also the state environmental health efforts. And I'd be happy, he and I talk regularly. The idea of if there are certain things that would make it easier for HHS to access that kind of state data and through a tool like this, I'm happy to have that be part of our discussion.
Okay. Yeah, we talk to him all the time. He updates the council every week, actually.
Yep.
Yeah. Thank you.
You're welcome.
So we're getting close to the end, and we have a tight 5-minute transition to the next session that starts at 2:30. So is there a final question or
Can we go to Bonita's question for a second?
Yeah, so let's go to, so how do Black, Indigenous people, colored communities, how have they accessed this data historically? Or I mean, maybe the question is, Bonita, maybe you can come online as well. Have they been accessing this data, Cliff? Do you know?
Yeah, so actually, I'd like to address that question and Janet Gingold's question at the same time, because I think they're related in some ways. And this gets to the question that I was trying to address at the very outset, which is causality and association are very, very complicated. And if you're looking at historic data and trying to understand what has happened to a community to bring it to the place where it is now, whether it's people of color, Indigenous people who are living in an area now, some of the challenge of figuring out what has happened historically and understanding what that means for the people who are living there currently and their health status today, it's really complicated to do from an epidemiologic point of view because people move. The same people who are there today are not necessarily the same people who were there before. But it does raise a really important point, which is as we present the data about current environment and current health outcomes, we try very much to show trends and to demonstrate and talk about the fact that even if you can't draw a straight line between a particular exposure and a particular outcome, that should never stop you from trying to improve the exposures and trying to improve the outcomes. And the challenge that I often have, and I will admit, so this is an argument and a discussion that has caused me to, I think, a great deal of discomfort because it's really an equity argument in some ways, and I'm not always very good at it. I will just say that right off the bat. I struggle with it, which is that historic oppression, historic redlining, red zoning, etc., clearly has happened, has clearly meant that some people are exposed historically out of all proportion because of racism and other factors. There's no question about that. That doesn't necessarily mean that it's easy to show statistically, epidemiologically, that an excess rate of cancer today in a population today is directly related to exposures that we can measure today. And at the same time, you can't deny the historic inequity of the exposure that has developed and in all likelihood contributed to that excess of cancer today. But in some ways, I can't show that epidemiologically with any confidence. So what I try to do as much as possible is get people to think about the fact that we know that that inequities and disparities of exposure today are likely to lead to bad and disparate health outcomes tomorrow. And so there's reason just to stop those from an equity point of view, regardless of what the health conditions of people are today. Similarly, inequitable health outcomes today are something that need to be addressed regardless of whether the exposures are disparate or not. You still have to deal with the health outcomes. So from both figuring out what the historic exposures are and also the difficulty of figuring out causation as opposed to association, I try not to make that the grail that everybody's going for at the expense of fixing either the disparity in outcome or the disparity in exposure.
We're gonna have to close this session, but I want to not yet, but I want to thank you for that comment, Cliff, because what it gets to is I call it the epi trap. Environmental justice folks, we avoid the epi trap because remember, as Cliff is saying, think about the EPHT data. Go back to, you don't have to show it, Cliff, but look at the exposures and the hazards and the health effects, which is a combination of exposures. It's multiple exposures to multiple chemicals, y'all. Multiple psychosocial stressors. It's multiple disease outcomes. So you cannot, it's not even one direct line, Cliff. It's multiple lines that come out of one chemical that connect to other chemicals. Our science this is the issue with EJ, with the EJ science. Our science is not keeping up with people's exposure burdens.
Yep.
So we know that's true. So we cannot let that stop us from, as Cliff said, reducing the hazards, hazard reduction, exposure reduction, improving health outcomes. We still have to do that work on both sides of the exposure disease paradigm, even though we would never be able to show causality. It is virtually impossible because of multiple chemicals, not chemical stressors, Cliff, but also non-chemical stressors.
Oh, yeah.
Stressors, biological stressors like COVID, physical stressors like radon, light pollution, humidity, noise. Our science, and that means our science is failing community impact by environmental justice. Our science is failing them, okay? But that doesn't mean we still don't act. So in public health, we'll still need to prevent, we'll still need to be nimble and agile, we'll still need to implement interventions on both the, as Cliff said, the inequity side of exposure and the inequity side of health outcomes. So I just really want to land on that last point, that we still need action for these communities.
Jacoby, I just would like to say one thing, and that's without acknowledging to the community and recognizing that there were past, things done. Nobody's going to trust you or listen to you. So, we've talked a lot about trust and what the scientific community has to invest in building trust, because people are not unaware of past evils, and people now are talking about using the word genocide when they're talking about COVID. So we have to really look at the community.
We're on the same page on that. I mean, environmental slavery, environmental oppression, environmental genocide. You talk about science, pain pippin science, guinea pig science. That's part of this story. That's definitely part of the story. But I think we're over time now. I want to make sure we're late on the next session. But I agree with you 100%.
And I agree with you also, Ms. Adib.
Yeah, and we're going to address environmental justice. And one of the principles of environmental justice, communities speak with their own voice with self-determination. You're exactly right. Historic trauma, and when I put the chat in response to Cliff talk about historic trauma. So we're talking about, so Benita, you mentioned genocide. His historic trauma and his current trauma, right? His historic trauma and current trauma. And as I said, not being provocative in one of the earlier sessions, I call it, Cliff, state-sanctioned poisoning. Why are we not doing zero emissions?
Yeah.
So state-sanctioned poisoning of communities, as Benita said, communities of color have been used as sacrifice zones. As Benita said, we have to recognize that we have environmental racism. We have to recognize that That's why we have the uprising against racism. I think that's part of the story as it relates to environmental justice. Cliff, that's part of the story as it relates to COVID-19. The history of medical mistreatment, medical malpractice, the exploitation of Black and brown bodies for science. We can go on and on. When it comes to the vaccine and COVID-19, that's another part of this discussion. I mean, so Benita, we had part of that discussion last Saturday, but you're exactly right. And it's important to take that forward. Thank you for that, Benita. We have to make sure we recognize those issues, because as Benita saying, we're not going to be able to move forward with using EPHT data if, as Benita said, you don't have trust in science, you don't have trust in scientists, and we don't recognize the past histories, the past traumas, and also, as I just said, Cliff, the current trauma and things that are happening in color.
Well
so,
said.
Thank you for that. I'm sorry, we're over time. Thanks. If y'all have any more questions for Cliff, I know, Cliff, you may not have got as much information you wanted out of this feedback, but I think it was a really good discussion. Cliff, please put your information in the chat.
Oh, yeah.
So Joe will send out information to all the attendees, the slides as well. Okay, please take care of that for us, Joe.
Please feel free to email me, and thank you all very, very much.
Thanks, everybody.
I'm going to upload Cliff's slides to the Google Drive link that all of the participants should have gotten, so you'll have the slides shortly.
Okay, and then we'll have 2 more concurrent sessions that are happening right now. One on climate change and resilience. And what's the other session, Joe? I'm not remembering.
I'm pretty sure it's pro bono legal tools.
Yeah, so if you're interested in pro bono legal assistance, that's a big issue. If going back to what Cliff said before about solutions and resources, we don't want to talk about the problems, we want to talk about solutions. We're going to have a session with lawyers who want to listen to your issues that you have with environmental justice, and they can provide some insight and support to your work, those to address those environmental justices. So thank you, everybody.
Thank you very much, Jacoby. Thank you all.
Y'all take care. On to the next session. Jump.